So I think we'll kick off now. My name's Sally Lewis. I'm the director of the Welsh Value and Health Centre, and it's my pleasure to introduce something new that is hopefully going to be fun and entertaining. We've had lots of requests over the last year as the value-based healthcare work has kind of gained momentum from clinical teams wanting to really discuss together some of the issues posed by the implementation of value-based healthcare and how they might work together to problem solve and run some of their own events. And Dave and Nick, who you'll see large on the screen in front of you today, were two of those individuals who have kindly agreed to try and experiment with us, which we're calling the Value Health Cast. The purpose of which is to do just that in a fun and entertaining way, hopefully over your lunch or at the end of the week, at the beginning of a Friday afternoon. And this isn't about a polished view of life. It isn't about, you know, as we've all experienced at conferences, going along and everybody saying how amazing and brilliant they are at the work they've done. This is the warts and all view of value-based healthcare on the ground, and how we make sense of it and move forward together. So we'll have a rolling range of topics which we would encourage you to suggest from the floor, and this will happen monthly. And we hope to make some recordings and hopefully some podcasts from this in due course. But that will be informed by how things go and what you are wanting on the floor, really. So I'll shut up now and hand over to Dave and Nick, our able chairs for the foreseeable future, I guess. Thank you very much.
Hey, so welcome to Value in Healthcast, where we're combining a webinar with the informality of a podcast to chat over issues that matter to value-based healthcare. So I'm Nick Wilkinson, a specialist paediatrician with an interest in value from setting up integrated regional services across the UK.
Hello, I'm David Hanna. I'm an emergency physician, and I'm really interested in understanding how systems work. I definitely believe in the old saying that every system is perfectly designed to get the results it gets. We're passionate about improving health outcomes and how to design systems that deliver patient-centered care, but also acknowledge that budgets are not infinite, and we've got a duty to be stewards of the resources at our disposal.
Okay, so I think first of all, we just have to feedback that I think we have overloaded the system here at Woodland House. So the camera and the projection from this may not be good. And if you want to switch off, well, at the bit for us, but don't switch off the bit which Navjot and Allan are going to present.
Yeah. Brilliant. So we've got Allan now.
Is Allan joined?
Brilliant. Okay. So just before I introduce our first guest, Dr. Allan Wardhaugh, what I'd like to do is just give you an outline of how the session is going to work. So we've got two speakers today, Allan Wardhaugh and Navjot Kalra. And we're going to have a 10-minute session from each of them, following which Nick and I will ask Allan and Navjot some questions. After the speakers, we're going to open the floor. So between now and really the end of the session, if you'd like to pop some questions in the chat bar, and then if you see a question you like, you can vote it up. And if you have your own questions, obviously pop them in the chat bar, and we'll sort of pick the questions that get the most votes and the most likes, and then we'll pitch them to Allan, to Navjot, and to Sally. So without further ado, I'd like to introduce Dr. Allan Wardhaugh.
My screen. Are you able to see my screen?
Yeah, that's great.
Good. Okay, so I'll put my slides up. And those of you that don't know who I am, I'm a paediatric intensivist by background, worked in Cardiff for just under 20 years. I've got a data and digital interest. I was the Chief Clinical Information Officer in Cardiff for the last 5 years that I was there. These days I work full-time kind of in Welsh Government, but building the NHS executive as well. And that's all about implementing the National Clinical Framework, which is part of what the NHS executive is going to deliver. So I'm going to talk to you about why data matters. So I'm going to start just with a bit of strategic context. And usually when I start with strategy, it's accompanied by a bit of eye rolling. But the thing is, if we don't have an understood common strategy, it's difficult to stay on track. So as the cliche goes, the main thing is to keep the main thing, but we all need to understand what the main thing is and also why it's the main thing. So strategy shouldn't just be something that you accept, you need to understand and believe in it as well. So our strategy has an objective, it has a clear objective, and that's the quadruple aim. And that keyword, quadruple, includes quality, another keyword. And that means that we don't need to keep saying quality all the time when we're having these conversations, because it's implicit in everything that we do. Quality is part of that main thing that we're aiming to deliver. The way we deliver is through this learning, health and care system. The philosophy that underpins it is prudent healthcare, and the toolkit that we use to deliver it is value-based healthcare. Prudent in practice is beyond the scope of today, but that's about the application or the need for everyday application of realistic, sensible, person-centred, value-based healthcare at an individual level. So the National Clinical Framework describes what the learning, health and care system looks like, and it provides the structure that joins together prudent healthcare and value-based healthcare. And that learning, health and care system can be thought of as having three main components. There's the practice to data piece, how we collect information about the population, the clinical interactions they have, their meaningful outcomes and meaningful experiences. D2K is how we turn that data into something that we can then use to understand, turning it into information and knowledge. Some people would add wisdom to that, which would be great, but I'll be quite happy if we can walk before we start running. So let's stick with knowledge. K2P, knowledge to practice. Maybe that's the most challenging bit. And this is where the national clinical networks come in, using the knowledge gained through that D2K process to re-inform and redesign integrated health and care pathways. You might think that this resembles a quality improvement cycle. There I go, using the keyword again. And that's because I would argue it is a quality improvement cycle. So again, showing that quality is implicit in this model. So the fundamental enabler of this approach is the ability to collect, share and access data in a single conceptual resource. And that's what the national data resource is and will be. Much of that data will be personally identifiable, linked data from across the health and care system, and we can use that for actionable insights, day-to-day operational management. But we can also strip the identifiers off and use it for more of a research context or a system understanding context. And it's eventually, when we're doing that well and we're collecting data consistently, that we can do the really sexy stuff that most people refer to as artificial intelligence, but those of us in the know just recognise as fancy statistics. But it's really important, and it's going to give us great insights into how we run things. And that's where the data platform sits in this schematic diagram of how our system will operate. An NHS executive setting direction, working very closely with national clinical networks and local planning and delivery organisations, putting those healthcare pathways into effect in a context that they're best placed to understand. So the health boards and other delivery organisations, they know their demographics, they know their geography, they know their workforce, so it's up to them to ensure that there's a local context. But accountability will be based on outcomes, and the national clinical networks will be integral to that outcome-focused approach. So let's talk about the topic in hand, the topic at hand today, so data to knowledge, D2K. So the fundamental to grasp here is that turning data to information and knowledge is a multi-step process. It doesn't just magically transform into Eureka-style insights. It needs people with different skill sets and not working in isolation from each other, and definitely not working separately or in isolation from clinicians. Visualising the data is a great first step, but how to make sense of it, how to work out what it's saying. And this is where we need clinicians and analysts or data scientists to come together to develop that understanding. We've definitely got the capability already within our system to do this, but only in small amounts. We've not got the capacity. So dashboards can definitely help to visualize the data, but we do need to move beyond that fetish. Dashboards, like other ways of interrogating, dashboards rely on the underlying data, and they can tell us some of the elements of what's already happening, but generally they tend to ask questions rather than provide answers. But that's okay, they're important questions, and it's through answering those questions or trying to answer them that we learn more about what it is we're doing. Our experience internationally from organisations and healthcare ecosystems that have had mature digital EPRs, electronic patient records, for a long time, which suggests it takes around a decade to develop real maturity as a learning health and care system. So it would be nice to think that we could maybe accelerate that a little bit and capitalise on the fact that other places have gone before us. So I just want to emphasise a little bit about this shared space for clinicians and analysts and data scientists. So my experience, hopefully I would imagine shared by many of you, is that clinicians have a hunger for data, but they're not quite sure what the data is that they want or what it might look like. They're also very starved of data, so you can effectively serve them up dog food and they'll tuck in voraciously. But they'll often be then disappointed that the data is not quite what they thought it was. It's not provided the information, it's a bit inaccurate, it seems to misrepresent reality, or it's already been misinterpreted by actors elsewhere that have come across the data. And I would suggest that if we persist with this model of kind of telephoned, emailed, transactional requests, then we're not really going to progress. I think instead we need to be a bit more like this. So we come together into an environment where there's a much more informed conversation. So I'm a graduate of the NHS Digital Academy, same as Sally Lewis. So you'd expect us both to highlight the role that clinical informaticians can play. So these are people who can translate between the two other groups in this room. I would hasten to add that you don't have to have had an NHS Digital Academy experience or education. There are many people who don't necessarily wear that badge, but who have the knowledge and skill set that would enable them to sit in that middle table and help translate these conversations. But you get the concept. I think the vision for the future that we have is that many of our multidisciplinary clinical teams will eventually incorporate data science and analytics in its conversations in the way illustrated here. Certainly once we do have a more mature EPR, so we're collecting much richer information. And this is what this looks like at the moment. In that data science and analysts table, there are a number of individuals from a number of different organisations, but therein lies the problem. There's kind of a custom and practice or grace and favour approach. It's all about knowing the right person or being connected with the right group of people, and it's actually quite difficult to navigate that landscape. So what we'd like to do is to develop a kind of conceptual front door, let's call it D2K Cymru, just as a placeholder name for the time being, certainly for a national space where national programmes, the national clinical networks and the NHS executive itself, the people that are actually in charge of running the system in Wales can come to get data, but to have that fostered conversation and really have the ability to develop proper understood insights into what the data shows. So I'm going to wrap up there, stop sharing my screen and move on to the next thing, I guess, maybe some questions.
That was fantastic, and as someone who is just that jobbing clinician who wants to develop their service, I think what I'm hearing here is exactly what I want to hear. I think that was fantastic. But also, you know, I have a lot of experience of dashboards and interpretation of dashboards, looking at specialist dashboards we have in the NHSE. Sometimes this just turns into league tables, and so people, all they look at is how do they reference themselves against somebody else, or as you identified, they go, well, I don't believe the data because I'm much better than that. What do you feel about that?
Yeah, league tables. So I've got that's a bee in my bonnet. I've got a lot of bees in my bonnet. I've got a bit of a hive of bees in my bonnet, but that's definitely one of the bigger ones. So that's all about how you present the data. If you present the data as a kind of ranked histogram, which I've seen, there's a lot of well-known organisations that will present data like that. Sometimes that's appropriate, often it's not. I would much rather see data presented with confidence intervals very clearly described around the data, and a lot of our outcome data needs to be presented as funnel plots, because that gives you a visual message that it's about quality control, and it's not about a position in a league table. But that's why we need people who understand data and understand that there are valid ways of presenting data and there are misleading ways of presenting data, because inappropriate use of league table visualizations can drive behavior that's got unintended consequences that aren't helpful.
I think I really liked what you said during the presentation about just being able to, how do we engage with the data? And it's not to set the question that proves that we're right. It's just to use the data perhaps as a mirror, but then it's, well, what does that data actually mean to us? And so it's just taking the raw stuff. So I really liked what you were saying there. Did you want to ask anything, Dave?
Yeah, I like that. I really like the aspect of measurement and data. I'm really interested to know what we can do to move from measuring stuff that we do, which is what we're quite good at the moment, versus things which are important to patients. And I think that challenges people like me who work in a business where we can measure stuff we do easily, but I'm not sure we're good at measuring quality outcomes. And I wondered if you had any thoughts about how we can get there, Allan.
Yeah, so I think, again, good question. We can't do value-based healthcare without meaningful outcomes. So PROMs are one form of measuring those meaningful outcomes, patient-reported outcome measures. So I suppose this is partly about a declaration of intent and a political, small p, political will to do this. If we agree that this is the model that we want to use to take forward, and we do agree it, because the minister signed it off and there's consensus behind it, then we need to collect meaningful outcomes. That then becomes one of the main things. And the main thing is to keep the main thing. So even though it's difficult, and even though there isn't a stack of PROMs ready to use that we can lift off the table, because we've made that declaration of intent, we need to be involved in developing a suite of PROMs that become available. But we need to work with international partners to do that. There's too much navel gazing within Wales. It's a small country. And a lot of time is spent one health board comparing itself with another. We need to be comparing ourselves with the other 4 nations in the UK, with the other OECD nations. So that's why international collaborations, such as those with ICHOM, the International Collaboration for Health Outcomes Monitoring, is important. And that's why it was really important that Sally and her team managed to attract the attention of the World Economic Forum because of the approach. So Wales, believe it or not, is a global exemplar as a health system because of its adherence to developing PROMs. But you know, let others talk about that later on.
I think there, Allan, you know, just sort of keep presenting that global burden of disease, and then, but just thinking, you've been sort of presenting something at a national scale, and then so how does it translate then down to service teams or to integrated care systems, you know, much more granular?
I think partly that's for organisations themselves to answer, but I would argue that you could use a very similar conceptual model, certainly at a meso level within health boards. And that was definitely the approach when I was in Cardiff and Vale. That was our strategic approach, to have those collective conversations with analysts, data scientists, clinicians. When I say clinicians, by the way, I mean all the people that come together to design clinical services, not just doctors, nurses and AHPs. I mean finance colleagues, operational managers, planners. But having those people in the same place, there were a couple of teams within Cardiff and Vale who were in, relatively speaking, data-rich environments. So critical care was an example, and they were employing their own data scientists to become part of their day-to-day team. And that's where the future lies, I think, for many of our services. So it's tentacles of data science reaching out through the system.
Thank you, Allan. I think what we wanted you to do is just to stick around. We would like to have a panel so that you join in the conversation then with Navjot. Is that okay?
Yeah, I'll stick around.
That gives us time then for more of a sort of a collaborative panel discussion.
Fantastic, yeah. So thanks, Allan. And so it's my pleasure to introduce our next guest. She is Navjot Kalra. So Navjot leads the value-based healthcare program in Swansea Bay. And she's also the Assistant Director for Digital Transformation in the Wales Value and Health Centre. So Navjot's an engineer and a computer scientist by background. And before working in the NHS, led international transformation projects for some of the leading Fortune 500 companies. So we're very lucky to have Navjot in Wales, and I'm really looking forward to what she has to tell us about the work she's doing currently in Swansea Bay, around value-based healthcare and heart failure in particular. So Navjot, over to you.
Thank you ever so much, Dave, for the lovely and kind introduction. I really appreciate that. Thanks, Allan. That was a really interesting presentation and an amazing segue into mine. So hopefully you'll, as audience, see the dots connecting as I go through a very practical example of D2K that Allan's already described. So first of all, let me see. Can you see my slide, my slide view and not all the slides? Is that right?
Yes, yeah. That's good.
Perfect. So I think what the question, the topic for today was unlocking value with data. So I'm going to be taking this example, and some of these slides are, from a very practical example of alleviating unintended variation and inequality in the heart failure pathway in Swansea Bay. Some of these slides are very clinical, and I'm really sorry I'm not. So I'm going to be just describing the process and actually relating data back to it. So let's start with the size of the problem for heart failure. Now, acute heart failure is the commonest cause of admission over 65. It estimates to about 2% of all NHS inpatient bed days. And if we look at the length of stay in Swansea Bay for heart failure, it's about 17 days against a national average of about 6 to 9 days. So that's the size of the problem. In terms of what sorts of services are required to address this problem, the sorts of services that are required to address heart failure as a condition are listed on the left side of the slide. I won't read them. And on the right hand side, now they become red. So in Swansea Bay, there was a number of areas where there was gaps in those services. So for example, we didn't have a dedicated pathway. We had no formal services for primary care, no services for cardiac rehab, etc., etc. And this is the strapline figure. If I was pitching to the industry, and I would say 14,228 bed days, acute admissions 3%, 10.1 million expenditure. I'm sure this will make a headline of a newspaper. But what I don't want you to focus on on is the strapline or the head or the big news in the Daily Mail. Swansea Bay spends 10.1 million on acute admissions because they don't have the right services. What I want you to think about in your heads is the money being spent at the right place? are we delivering value, and what's the value of 70% of the overall heart failure expenditure being used on acute hospital admissions? So for a minute, just reflect on this. This slide shows the typical course of heart failure from the time of diagnosis to, unfortunately, some of the outcomes from this disease are the end of life and death as an eventuality. Within this typical course of heart failure, the slide that I described to you previously, and when I started working with the clinicians and started understanding what this was, I had to chunk it down into many different parts. So what we're talking about is, during this pathway, an improved diagnostic pathway to improve things, a primary care framework, because our heart failure prevalence is underreported, improved access to heart failure community specialist nurses, but how many do we need? What's the size of the community model? What's the size of the workforce? When we talk about specialist involvement, how many acute admissions, how many are we going to reduce? So that kind of begs the question around, when we look at this whole big spectrum of a process or a pathway in healthcare, from a data perspective, we've got to chunk it down into smaller parts to understand what's the patient's journey through the system. So this slide shows a typical journey of a patient through NHS Wales. Now, this journey might look a bit linear, but is definitely not linear. So the patient can present themselves at any part of this overall pathway, and although we expect it to be linear, it generally isn't. However, behind the scenes, on every interaction that the patient has with the system, there's a number of systems behind the scenes that capture data from those interactions. The circles on this screen, the red circles, are the data that's routinely collected in a patient's journey through the system. So visualize a heart failure patient throughout the journey in their system. These are the sort of systems that sit behind the scenes to capture the data. The difference between the red circles and the green boxes is that the red circles are routinely submitted into a data warehouse that sits in an organization. So all this data is collected routinely within health boards, within health, within GPs, within the various laboratory systems, admitted patient care systems, and there's a lot of abbreviations. So I'm not even going to start de-abbreviating them. I'm really sorry, but that's a conversation for another time. But really, what we're talking here is that 80% of our data is collected on 80% of the systems on a routine basis. So we got a lot of data being collected at all times. The green boxes, however, are the ones where data is collected, but perhaps not routinely submitted into one place. So what that means is that we have the ability to answer some of the boxes that I showed you previously on a heart failure pathway around what does it mean not to have a service provision that actually delivers the outcomes for the patients. Can I understand what my baseline is for how many people are not able to are not being given proper diagnosis or proper treatment for heart failure, for example. And actually, when we start talking about value, the two components of value are the appropriate resource and the appropriate outcomes. So in that landscape, what generally tends to happen is that we've got a costing activity data sitting in one system. We've got a registry data sitting somewhere else. We've got patient reported outcome measures sitting somewhere else. And actually, more than often, we will not have them underpinned by proper data standards or proper interoperability requirements so that systems don't talk to each other. So the landscape becomes kind of complex. However, even through that complexity, what's in the art of the possible is to be able to use data or intelligence at different levels. So the three things I'm going to be talking in the context of heart failure now is how we look at a macro system level information by triangulating some of the data that comes out of all the systems I talked about together. How do we then start utilizing this data on an organization level, which is the meso level? And actually, how do we then look at the meso level, but then start digging out into bits that require improvement? So for example, the micro level or the individual level. So when I showed you that busy slide with all the acronyms, if we were to look at all the systems that data is collected on, this is a snapshot of the National Heart Failure Audit Summary Report. It's quite out of date. It's from 2016-17, and as such does not reflect the NHS organizational boundaries pre-April 2019. The only thing I'm trying to illustrate on the slide here is on a macro level, we can see how admissions compare, how many people had moderate or severe edema, what was the involvement of consultant cardiologists in Wales when people were diagnosed with heart failure. And already this starts surfacing out some of the inequities, and it starts surfacing out some of the provision of services. But for example, the heart failure specialist nurse, about 17% in Wales. Again, way less than the NICE guidelines for heart failure. What's not possible in this particular visualization is to understand why this is happening, and whether it's whether this variation is intended, unintended, unwarranted, warranted. And that again, you probably need to go another level down in terms of so what do you do in heart failure? Well, you first of all, you understand how many how many people are being tested for their pro-BNP testing, for example. What was the length of stay at the time of baseline? How many admissions were there when you didn't have an ideal pathway? So even before you make any changes in a clinical redesign or a pathway change, it's really important that we use a question that you asked Nick earlier about, or I think it was Dave. How do you translate what Allan showed on the D2K, the national thing? Well, we've got enough data in our data warehouses in health boards as well. So all that information is in your data warehouses, but you need to ask the right questions of the people who can provide you this information for you to be able to do something like this on the screen to say, actually, before we made any changes, there was 30% more acute admissions before specialist review, and now we have 30% less. Before we made changes, our length of stay was 2,200 beds more than what we have now, and actually our length of stay has reduced from 13 days to 9 days. So some of these information then reflects that some of the performance and the outcomes from a clinical redesign are either successful or not successful, because sometimes actually when you measure things and things are not improving, it's good to fail fast, but you won't be able to fail fast if you haven't got some of these measures in place. The next slide, I find this really interesting as well. But again, if we are to then look at the next level, which is the micro or individual level, again can be kind of visualized for two different user cases in here. The top left chart shows the pro-BNP testing. So the average days between the pro-BNP testing, so average days between the secondary care referral and the first attended clinic appointment based on the implementation of the pro-BNP testing, which was not that widely adopted earlier, and actually how the average days before review come down over a period of time for all those different scores of the pro-BNP testing. And that's really important because through the use of the visualization and through the use of informing the clinicians at all times on what is happening in the system, they can see what good looks like. At the same time, we trigger PROMs in heart failure, which allow the clinicians to see that the cohort of patients or the individual patient is actually faring okay in terms of their quality of life. Their quality of life naturally will deteriorate over the course of the illness. However, you can see that the quality of life in this case is stable, and in some patients it might not be stable. So again, 3 examples that I've shown you of how you use macro level data from exactly the same data sources. You can exactly use the same sources for measuring over time with the meso level information. And should you wish to make any improvements with the micro levels, these are 2 examples of that. But the data sets behind them are same, the questions are the same, the baseline is the same. And so the conclusions and the so what is, well, data really is the key to understanding variation, reducing harm, and measuring cost and outcomes. And with utilizing the data, a number of inequities in heart failure were identified. These were then baselined. And these inequities, data can't address those inequities, definitely not. The inequities were then addressed through the implementation of condition-specific pathways and redesigning the model of heart failure service, including delivering chronic condition management in primary care. We then assessed the impact of interventions, as I showed you previously, using PROMS, outcome measures, including case mixes and clinical outcomes. And these all things fed into the case for change for reallocating those resources to deliver value. So what we then saw is the value, the resource that was being utilized in acute care could then be moved into resource where it made much more of a difference in terms of identifying heart failure earlier and doing something about it. And hence the continuous measurement and impact of change monitored and reported and that ensured improved resource utilization and outcomes, which is what value is all about. So that's I hope that was useful, and that brings me to the end of my presentation. Thank you very much.
Well, Navjot, thank you very much. I mean, you started with an apology saying you're a non-clinician, but you demonstrated a pretty impressive grasp of what's a very complex clinical pathway. Thank you very much. I've got lots of questions, Nick, but I've got a question about measures, Navjot, and I'm just wondering, were there any measures that were novel or that hadn't been looked at previously that you and the team identified? Or did the heart failure team come to you and say, these are all the important things?
Yeah, so I think it was both. So most of the measures were driven by the quality statements from NICE. So if you look at the quality statements from NICE, which describe what should be measured in a heart failure pathway, I think most of the measures were matched to those quality statements. So that's the first, and those will have come from the clinicians themselves, because clinicians know their subject the most. I don't, and my team doesn't, in the rightest possible way. However, PROMS definitely was a novel data introduced in this pathway. The implementation of PROMS is quite complex. It does require the integration with the current patient administrative systems, and it does require specialist input to collect patient-reported outcome measures in this case. So PROMS definitely was something we helped the clinicians establish, adopt, utilize, and be a part of the business as usual. And just to caveat this, we've had issues with PROMS in heart failure, only because of the length of the questionnaire at times, and only because of the lack of adoption sometimes from patients. So whilst we've had a huge success in PROMS in other services, perhaps in heart failure, not that much. But I just, so there have been challenges in doing that. But definitely the intention is there and the aspiration is there to scale it up more than we've been able to.
Thanks, Navjot. This is all brilliant stuff, and what I really liked was how you took complexity, and you sort of, by having the layers of information, so it's sort of the dashboard at a national level, and then looking more then at the granular detail at either a health board or at a hospital or at a patient level. So that requires then a lot of data analytics. So do we have access to you for all of our services, or how do you imagine that this will work?
Okay, so what I'm going to say that is the demand of analytics and the demand of data science is growing at an exponential rate globally. It's not just NHS Wales, and there are far and few, and the capacity of data analytics is not keeping up with the demand. So what we are always going to have is the shortage of resource and time and ability to do it. There isn't a one-stop solution. So I'm going to answer this question in two parts, if that's all right. So the evidence tells us that regardless of how much we try and how we try to cut it, we're never going to be able to fulfill the full demand of it. However, there's also evidence that points out on collaborative working, on careful prioritizing. What does the system want? And actually, can we align our priorities with the overall system to the best of our ability? Sometimes there will be things that are bespoke, and how do we bring multidisciplinary groups together? So Allan described the model around bringing analysts, bringing people together from various organizations to solve a wicked problem. So there is that. And there is the idea of business intelligence competency centers, which are all about bringing a number of people together to solve a shared problem. So that being said, you definitely have access to me and my team, and you definitely have access to your health boards and the digital teams. But I guess the idea here is to be data literate enough and actually be able to formulate some great questions. And having a little bit more sort of insights into the way our systems work and the constraints work. Because just by going up and saying, oh, the data quality is shit, rubbish, I don't like it, people don't engage, I think sometimes that attitude doesn't help. But actually being mindful of the limitations on the resource and allowing people to prioritize your request, I think is a good thing sometimes. So
I think what I'm hearing is that it's empowerment, and but with that comes responsibility. My responsibility then is to understand, data and how we would assess it, and then the workarounds. Workarounds, all the data that we've got. That's the data we've got. So what can we learn from that, and then how can we improve care?
Absolutely.
I'm aware that Dave and I quite happily would ask you millions of questions, and I think you would know that. But we do need our audience to start asking questions, because we would like this to be interactive. I think this is a new thing for us all. So please, could somebody just sort of start to pop questions in, and then we need others just to like those questions, and so we can have then an active process about asking questions. And I think what we could do now is move on to the panel. So if we bring in Allan and hopefully Sally, if there.
And as we do bring in Allan and Sally, Navjot, I was drawn to the headline figures on your first slide. That 10.1 million pounds is a nice round number, and you mentioned about the resource liberated from reducing the acute admissions and the potential to redistribute some of that resource to primary care, which is easy to say, but I guess in practice very difficult to do, because the money doesn't just pop up in another place, does it? Have you had success with that? Redistribution?
No, so Dave, that's a really interesting conversation and a topic of discussion at one of the national heart failure events we had a couple of days ago, which the Welsh Value and Health Centre hosted. And this is the wicked question, is that when you redesign a pathway, resources are released in other parts of the pathway which might not sit in the same budget. So hence the question around, well, who benefits from it and who releases it? Now, in the case of heart failure, there has to be had some sort of seed funding or some sort of pump priming to be able to deliver some of those benefits. But we're still not there in terms of a complete reallocation of resources, although to a certain degree we are getting better at that. Sally, do you want to come in there?
Yeah, thanks, Navjot. Yeah, so it is the $64 billion question, isn't it? And the truth is, I mean, what I've learned after a couple of decades of talking about shift of resources from secondary care to primary care, realising that there is no shift as such. It's how we reallocate and utilise over time, and that's the language that our finance colleagues use, and why the language of value is so useful in drawing the clinical world closer to the financial world. And it might be, you know, that the investment is needed in primary and community care and you can't get it in year, but then you've got to think about how you use the planning process, you know, with your finance colleagues advising you in the room to make the case for that investment or allocation next year using the planning process. So a lot of this is about, you know, once you've had that actionable information that Navjot and Allan have talked about this afternoon, how you engage other parts of the system to help you act on that, particularly when it involves some kind of major multi-layer service transformation. So really useful to have your finance and planning colleagues alongside you every step of the way.
Allan, did you have a input onto?
I think the points that Navjot and Sally have covered sum it up basically. I maybe just want to draw attention to something I put in the sidebar, because it seems a little bit facetious, but it's actually serious. So it's about becoming data literate and acquiring data literacy skills. So it doesn't mean that you need to learn how to do logistic regression or, you know, assemble random forest plots or program Python or anything like that. It's more about just understanding the general principles of interpreting data and the pitfalls of misinterpreting data. So I've drawn attention to more or less the sort of regular series on Radio 4. That's the kind of data literacy I'm talking about. You know, it's not sophisticated stuff. It's relatively basic, but that relatively basic stuff gets forgotten all the time at very senior levels in our system, and more or less exists to highlight the many examples of that happen. So I genuinely would encourage people to think about their data literacy in those terms.
And I would reinforce that, because just at the level where I work, you know, just any data is great, but it's amazing how you can use that data for the insights into your service that acts as that ability to reflect what you're doing. Now we've got a question here from Mark Thomas from Improvement and Implementation. He said, you know, so do the panel believe we have the right business information systems with the capability to provide the right analysis rather than the misleading? And do the teams using these systems have skills to provide the analysis?
Can I come there?
Yeah.
Okay. So you know, just from my previous life, there isn't a business intelligence system I have not worked with, and that includes a number of systems, including Tableau, Click, SAP, Oracle, Softcat, and I mean I forget the names. And if you look at the Magic Quadrant, there's a Magic Quadrant from Gartner, and you can see all the different sort of business intelligence and visualization suppliers. And I can assure you, Mark, it's not the system that does the right analyses, it's the people, and having well-trained people who understand the complexities and actually, in particularly the health system, get their findings validated from the clinicians is what makes all the difference. That's my brief answer to that.
Yeah, I'd like to come in on that as well. I remember looking at the Gartner stuff a few years ago, and of course, if you look at the Gartner stuff every year, year to year, the different business intelligence systems move around in that scale. The point I wanted to make was it's really important that when we are acquiring new business information tools, so it's not just about one system, there are a number of different tools for looking at data. It's really important that we have the data scientists and analysts sitting at the table informing those purchasing conversations. I think the idea of people who don't fully understand data systems and aren't fully data literate going to the shops and buying something and then saying to their teams, this is what we expect you to use, doesn't work particularly well. So another part of building that D2K capability, that D2K room, is to make sure that those sort of purchasing decisions, even when it's involving working, which we should do, we ought to do, working with private partners to help improve our capacity, but it needs to be informed by the people that have actually got the understanding, not imposed from above.
Oh, thanks, Alan. And I can see Mark's come round for another bite of the cherry here. Mark said, having worked with so many teams to make pathway improvements, it's clear that many teams use sort of supplementary systems, so Excel and so on, when the organizational systems don't present maybe the functionality they're looking for. And Mark's question is, how can we as a system ensure that the clinical teams don't need to create their own systems so that all the data they need can be recorded and then analysed appropriately? And I suppose with the onset of Teams and Power Apps and Microsoft Forms and everything else, that's a pretty pertinent question, isn't it?
It's a very good question. It's a sort of shadow IT, but shadow IT in the data realm, I think is what Mark's describing. So for those in the audience that don't know what that term means, so digital IT professionals will refer to shadow IT as all the IT systems that people in the organisation go off and develop themselves, and it causes a lot of consternation in the central IT team. And I remember having these conversations with colleagues in Cardiff and Vale. You need to be mindful how you have those conversations, because the reason that shadow IT emerges and develops is a symptom rather than the cause of the problem, I would argue. If the capacity and capability isn't made available, then people will go off and do their own things. We all are in this business because we want to make a difference and we want to improve things, and you won't stop people trying to do that. And why would you want to? So I think the answer is to grow the capability and capacity in the centre, and then the shadow IT stops becoming a problem. In the short term, there is going to have to be a bit of curation and a bit of management, but that's a process of dialogue and engagement rather than a series of sticks being used to beat people.
I just want to add to this because it has such clinical utility. So the data, because all the databases that we tend to create in our services helps us to deliver the care that we need to deliver straight off. And so that's the reason that we do this. But I understand that there are governance around this, and we want the systems to patch, and we don't want double data entry. And so it's vital that we get this right. And so I'm really glad what you're saying. Just before we finish, because I think we've just got another sort of 5-7 minutes. Just people whether to poll whether they want another session on data later with the next session. So is data what people want? And then we can think about presenters around that, because it'd be nice to have some services presenting how they've met with the challenges of data acquisition. So please put into the chat box if that's something that you would like. Was there any other questions you'd like to ask, Dave?
Yeah. So Joanna Charles has asked a question. Joanna, it looks like is part of the finance team, and she's asked, have costs been considered as part of data intelligence? And it would be great if we could develop a catalogue of costs for Wales NHS service use. So has anything ever been done like that to quantify or to catalogue costs of these sort of services?
Yes, so I'll jump in on that one. So the short answer, Joanna, is yes. Of course, the type of costing that is used very much depends on the question that you're trying to answer, as you know. And I think probably that's a whole session in itself, is how we use financial information. So we'll log that one, watch this space.
Brilliant. Thank you. And so finally, I got a question from Sarah Dunderdale, who I think, Navjot, is a colleague of yours in Swansea Bay. And Sarah is asking, what can be done to improve data quality as it goes into systems?
Okay, so I have a politically incorrect answer for this. I'll go for that first. So data quality is everybody's business, right? And the other thing I'm going to say is I worked in international systems and worked in the Nordic countries for a while, and where I saw that in health, in particular in secondary care, clinicians were responsible for coding their own information. So I never saw the concept of coders in the Nordics. So and that kind of, but of course, you can't create a new system. So I think it's really important that we have we have that balance between training the coders, having an appropriate resource in coding, and actually training them appropriately so information is coded. And there is and the classic is the more data you use, the more data quality you're going to improve by identifying some of the quality issues. But again, if we get stuck on I already use the swear. I never swear. I don't know why I swear before, but I mean, data quality being rubbish is everybody's business, and the person who says it actually needs to be responsible for improving it themselves. So,
and I think there's something for me about having a skin in the game. And if you're a clinician and you're practicing, or you're a finance team, or you're anybody in health, and you're trying to deliver outcomes that matter to patients, and that's been measured, then you would hope then that the motivation to record good data would be there. Allan?
Yeah, this is something I'm particularly keen on too. So there is a chicken and egg thing here, because the way you drive up the quality of the data is to make the data useful every day, or to make it important. Usually this conversation goes down the cul-de-sac about payment by results, and why don't we have that like they have in England? Nick will tell you that has just as many unintended consequences as benefits. One of the ways that I saw data quality driven up in my own service in PICU is because we were monitoring important outcomes, mortality, but in order to properly understand mortality, it needed to be risk adjusted. And it was risk adjusted properly, not an ad hoc back of the envelope 5 or 6 confounders that some mortality tools use, but a properly validated logistic regression model that was tested and learned and iterated. And that required quite a big data set to be collected. So if you didn't collect your data accurately, then your mortality data was incorrectly reported, and that might make you look like a very poorly performing unit. So that was a real driver to improve mortality, and that happened across the UK in PICU. It took about 2-3 years for data quality to get very high, because it was in people's interest to make sure the data was accurate.
Oh, thanks, Allan. And I'm always envious of the quality of data coming out of neonatal intensive care and pediatric intensive care. I look at it quite enviously. So thank you for that. And I think that's probably nearing the end of the session. So there's probably a few things for Nick and I really to reflect on at this point in terms of what we talked about today. For me, there's been some really amazing key messages. A lot of the work that's underway, I guess, where Allan and Sally sit is unseen to clinicians, and it's reassuring and encouraging that work's is underway, because as you look to the future as a clinician and as a service, this is the backbone of how we're going to improve care for patients. So that's really encouraging. And then listening to Navjot talking about the heart failure project in Swansea Bay just has me thinking about all the process measures and outcome measures for my own patients and service, and how we can learn from projects and initiatives like that in Swansea Bay. So thank you both, and thank you to Sally.
Just the feedback on the poll. Yeah, we want loads more data. So I think that might inform the next one, but it won't be all about data. Future podcast, these Value Healthcasts, we do already have loads of topics that cuts across all diagnoses, all organisations of healthcare delivery. And so some of the points that we've key points. It's everybody's business. Andrew Nelson said it's about data democratization. I'd agree with that. Systems need ongoing design and support, and I think that was spoken to. We need to embed problems, and it can manage complexity. So I think we really, I think the future's looking bright.
Indeed. So from Nick and I, thank you to our guest speakers, Navjot, Allan, and thank you to Sally and her team from the Welsh Value and Health Centre, particularly Brooke and Samantha, who've been working hard out of camera here. And thank you to everybody who's attended. It's been wonderful delivering the session today. We hope it's going to be the first of many future sessions. Please let us know what you think. Thank you very much.